Welcome to this month's community engagement webinar. It's not normally on a Tuesday, so we appreciate you taking the time to jump on and watch this live. But Gary, we're having a Hospital of the Future meeting this Thursday.
We are, yeah.
And Gary's going to be able to share with that Community Advisory Council all of the wonderful things that are happening with Cahuilla Health's facilities. But today we are going to cover the July financials. We're going to cover the Stanford contract. We're going to talk about just the different things happening around Cahuilla Health that our community advisors might want to know. Like we say every time, you can either chat in and Daniel will get me those questions, or you can text me for those of you who have my cell number. We are happy to answer anything live, and then you can email and we'll follow up after this meeting. So welcome, Gary. I hope you're not as tongue-tied as I am.
As you are. Should we hit the do-over button?
Maybe.
Well, we can certainly edit it for what we put on our website.
Yes.
But you're streaming live to our members right now. So.
But everyone who normally streams live with us, they're normally my friends, and they have a lot of mercy, and they extend grace to me.
I'm sure they were laughing right along with you.
Yes.
So where do you want to start?
How are you doing? Well, why don't we just start casually? How are you doing?
Yeah, good.
Good.
Yeah. Busy. I did take a 2-week vacation.
How often do you do that?
Rarely.
Yeah.
I mean, I take long weekends here and there, and I think generally my vacations are about a week. But so yeah, it's been a while since I took a 2-week vacation, but it was nice.
Yeah. Did you go somewhere fun?
I did. My wife and I and our good friends from Fresno took an 11-day cruise, Norwegian cruise. We flew to London and then drove to Southampton, England. And the next day we set sail for Belgium and Amsterdam, Norway, and Iceland.
Wow.
Yeah.
That's a lot of...
It was. I mean,
to cover in 2 weeks sounds long, but...
It is, yeah. And, you have a couple days at sea, which are kind of nice because that's just your downtime. Other than that, you're going into a new port every day. And but what was, really wild about it is London, Amsterdam, Belgium, beautiful weather, mid to high 70s, shorts and T-shirts. And then we get to Norway, and it's 45 degrees and raining and the wind's howling, and it was that way in Iceland as well. So it was a little challenging to pack. I guess the layering definitely was the approach. And I find that the older I get, the jet lag is harder. It's a 9-hour time difference. So, and you're trying to stay awake or force yourself to go to sleep to get on those times. And I didn't do particularly well. So it was probably good that we ended up getting back like at 1 a.m. on Friday in Fresno. So I did have the weekend to kind of decompress and reacclimate.
I don't know about the rest of those countries, but London, it being light until 10:30 at night, that shook me up a little bit.
Well, that's actually Norway and Iceland. I mean, Iceland, there's a period of the year that they have like 22 hours of sunlight in a day. They have very little. Definitely the sun was setting like at 10:30 at night. But the blinds in our cabin were very good.
Thank goodness for blackout curtains.
Yeah, exactly.
Well, welcome back to the real world here at Cahuilla Health.
And it feels like I wasn't even gone, believe me. There's no easing back into the work life.
Right.
Definitely right out of the gate.
Right.
Yeah.
Hospital's very busy. ED is very busy, so we're going to cover some of that. But let's start with the July financials.
Yeah. Well, just to kind of piggyback on what you just said, our financial results and the revenue we generated is greatly, if not entirely, influenced by patient volumes. We do, in some markets, there's more managed care penetration than others. Tulare County has kind of been like an eye in the storm, or the center of a tornado, in that we don't have a whole lot of advanced managed care. Definitely we have a lot of managed care plans like Anthem Blue Cross and Blue Shield and so forth. But Humana, our Medicare Advantage plan, is the only health plan we have with about 14,000 lives that we're paid on what's called a capitated basis. And so we just receive a premium, a share of the premium that Medicare pays to Humana for those enrolled in that plan. We get a piece of that. And we get that every single month times 14,000 members, and that's our total revenue. So if a Medicare member, Humana member, never steps foot in the hospital, we get to keep that revenue. But if they come to the hospital frequently, we don't get paid anything for that. We've already been paid in that premium. So it's really interesting that if you have a lot of capitated business like they have more in the Bay Area and Southern California, you're highly incentivized to keep patients really healthy and well and out of the hospital. That's how you're profitable. Whereas if you're fee-for-service, which is the majority of Tulare County, you don't really get paid for keeping people healthy and well. You only get paid when they come to the hospital, when they get admitted, when they come to the emergency department. So it makes you a little bit schizophrenic. Ultimately, and it's not happening as quickly as a lot of people predicted, ultimately, all of the U.S. population will probably eventually find itself in one of these managed care plans where all the incentives are aligned, physicians and hospitals, to work together to keep people healthy and out of the hospital. But for the time being, Humana patients, we do everything we can to keep them out of the hospital, and then everybody else, we welcome them to the hospital. Not that we like to see people sick or injured, but it directly influences our financial results. We do continue to get busy, although it's very interesting. I was looking at this morning's census. So I look at particularly the adult census, and there have been many times we're running well over 100%. This morning we were at 87%, which sounds, wow, that's great. So you got room to breathe and everything. What's interesting is the availability is really concentrated in our critical care areas. So we have between the medical ICU in our West Tower and the cardiac ICU that's in the Asequia wing, we have 41 total ICU beds. 20 of them are empty this morning, so roughly half of them are empty. And then we look at intermediate critical care. So we have 30 beds on 3 West, again in that West Tower, and then we have 24 beds in the Asequia wing. So of those 54 beds, 16 were open and available. Then you come down to the medical surgical units where the majority of our patients are admitted. So 2 north, 2 south, 3 north, 3 south, 4 north, 4 south. Altogether, there's 237 beds in those units, and only 8 of them were open this morning. So that's where we're feeling the greatest amount of stress and pressure right now. Fortunately, this morning at 7 a.m., we did not have a single patient holding in the emergency department that a determination had been made to admit them, but there wasn't a bed open. That's unusual. And you talk about the unpredictability of the ED and even our census. Melinda Tupper, our CFO, we had a finance committee meeting last week, and she was showing us the daily census by day, say in July and August. And it looks like a patient, a heart rhythm where the patient has tachycardia or something. And it literally fluctuates rapidly from day to day. Last week, there was one morning at 7 o'clock, we had 31 patients holding in the ED waiting for a bed to open up. And today we have 0. So it's so unpredictable. I am glad to see that we have availability in the critical care units. We had 4 traumas come in this morning, motor vehicle accidents. So you never know. That's the life, a day in the life of, a hospital is every day is a new adventure, a new experience. So financials. Let me first, and I probably shared this with you last month, but Our fiscal year ended on June 30th. We just met with our auditors, Moss Adams, who are kicking off their annual audit of our financial statements. They will present those financial statements to our board of directors at their meeting in October. And provided that nothing changes between the internal financial statements that we've shared with our board and what will be opined upon by Moss Adams and presented to the board, we will, I'm very excited to report that we finished this last fiscal year with both a positive operating margin and a positive bottom line. The only difference between those two really being investment earnings, which are considered to be non-operating revenues. So we had actually budgeted for the year to have a $22 million operating loss, and we finished the year at a positive $3.6 million. So literally $26 million better than what we had budgeted. And really what drove that, higher patient volumes. We did our patient revenue came in about 14 million higher than budget, but also these various Medi-Cal supplemental funds that we participate in as a district hospital. Big shout out to the District Hospital Leadership Forum, which was formed about 14 years ago. It exists for the sole purpose of helping the 33 district hospitals in California increase their revenues to be able to continue to keep their doors open, expand services. Unfortunately, we're seeing more and more hospitals, including district hospitals, close their obstetrical programs. I think you're aware that while Tulare Hospital is no longer a district hospital, they're a private nonprofit operated by Adventist Health. Just a couple months ago, they closed their labor and delivery unit. So about 22% of the 33 district hospitals have similarly had to close their obstetrical programs. So these supplemental programs are designed to, help hospitals stay open. This last year, it amounted to about $100 million in additional Medi-Cal funding to us. Not a penny comes from the state. It all comes from the federal government. But I cannot imagine how any district hospital could keep their doors open without these very important supplemental programs. So when you throw in investment earnings in the last year, we actually finished with a positive bottom line of $18 million. Juxtapose that against the $40 million net bottom line loss that we experienced in the previous year. So literally a $57 million year-over-year swing. So if all things remained the same, we would have expected in the new fiscal year that started July 1 that we would carry that momentum and those positive results into the year. However, and I won't say unfortunately, because nobody works harder than our employees, our 5,000 employees that are the heart of this organization across so many different positions. But in fact, 3 of the board members and I, we toured earlier this morning 2 very important but very much behind the scenes operations of Quia. So the first place we went to was the telemonitoring room. So we had 6 employees in there, and they both have 2 giant monitors in front of them. And they were managing 171 patients this morning that are scattered throughout the hospital that are on telemetry. So we're monitoring their heart rhythm, their heart rate, their oxygen saturation, blood pressure. They're in a patient room, in a patient bed, hooked up to a monitor. But this group of 6 is in a completely different place of the hospital, in a room, monitoring, the rhythm strips, and their phones are ringing off the hook, and alarms are going off, and they're getting on the phone and they're calling the nursing station and saying, Mrs. Smith, her O2 sat just dropped to this, or Her blood pressure has gone to this. And, the nurses are on the unit, are monitoring these patients, but it's like another set of eyes that is continuously monitoring the patient. And it was just amazing to think, how many patients were being monitored. And it's a reflection, unfortunately, that we have, very prevalent cardiovascular disease in Tulare County, probably some of the highest in the country. And with all that cardiovascular disease, even though, a patient is in for, a gallbladder, a respiratory failure, or some other condition, they also have a bad heart. And so we're constantly, monitoring their heart as well. And then we went to the first floor. That was up on the 4th floor. We then went down to the first floor and went into this room, no windows, 3 employees in there, and they've got these, again, giant screens in front of them, and they are called telesitters. So literally, we have cameras and microphones in the room with the patient, not just in the acute medical center, but also at rehab, skilled nursing, subacute over on Court Street. They had about, I'd say, 70 patients that they're on the screen and they are viewing these patients live. So they're not just looking at a heart monitor strip. They have eyes on the patient and they're watching them 24/7. And when the patient, and they're generally there because they have, they're on a telesitter because they have dementia, they're a fall risk, they might have confusion, they might be attempting to pull out their lines, their peripheral lines or central lines. And so if a patient starts to get out of bed, they can hit the mic and say, "Mr. Smith, please sit back down. I'll have the nurse come in right away." So for the most part, our sitters are physically outside the room watching the patient and have to be able to respond in a split second, if they try to. But we're able to kind of supplement that with leveraging resources, rather than a sitter watching one-on-one, we can have a telesitter maybe watching 14, 16 patients all at once and be able to communicate with them as well as their nurses.
Yeah. Well, and I did not realize that it was so strict because, I hear of sitters and stuff and I think, oh, somebody's just in there kind of watching and paying attention. But on the employee huddle a couple of weeks ago, I don't know if you remember this, when the question came through about telesitters not being able to read or not being able to do anything that would distract them.
Right.
Their job is to just watch the patient.
Yes.
And so I had no idea. I thought the telesitters were like somewhere far away, but it's actually, we have a team in there.
Well, the physical sitters are literally sitting outside the door,
right,
with a line of sight, ready to jump up at any time. The telesitters are, yes, they are in the hospital, but they're in a room right where housekeeping used to be, because their normal room is right outside the cafeteria.
Okay.
But some electrical work's being done. But they're in this room by themselves, no distractions, and they've got their eyes on the patient and they're watching them, able to talk to them.
Wow.
Yeah.
Wow.
It was
That's
fascinating.
intense,
But I come back, they're part of the QUIA team, vital part of the organization. And there's been a tremendous amount of volatility in the market relative to the healthcare workforce, the labor market. And so, unfortunately, it's almost like a wage war that's being waged, not just in California or the Valley, really across the United States. We lost tens of thousands of healthcare workers because of COVID. We still have almost 500 open positions, still less than 200 open RN positions, but close to 200. So to be able to attract and retain those outstanding staff, we need to continue to be competitive in the marketplace. So to be competitive and be responsive to the market, as well as to react to the new law that went into effect that increased fast food worker minimum wages to $20 an hour on April 1 of 24, and then Senate Bill 525, which is ultimately going to increase the minimum wage for all healthcare workers to $25 an hour. The governor kind of pulled a fast one on us, unfortunately. 2 weeks before the law was to go into effect, he got the legislature to pass an amendment to stall it till July 1, and then he has received further delays that may go all the way till January of 25. But in the meantime, hospitals like us across the nation, we couldn't wait to say, okay, we're going to put this in effect on June 1. So we already started making wage adjustments to bring our staff up to their new minimum wage. When you couple all those things, we literally increased our total labor expense by $32 million. So if you compare last year's, total labor costs, which for employed labor was $353 million, is what we paid out in salaries. So we have added another $32 million on top of that, without receiving any additional increase in reimbursement from Medi-Cal, maybe 2% from Medicare, something around that from our commercial payers. So as a result of that, we actually budgeted to have about a $21 million operating loss for the current fiscal year, which is disappointing after coming off such a positive year. After 4 years of really tough sledding, to have a really positive year last year and hoping to build on that, we simply weren't able to do that. So we're off to, I would say, a good start. So we got 1 month under our belt. Obviously, August will end here shortly. We'll know how we did in August, about the 10th of September. But for the month of July, we incurred an operating loss as expected, but a loss of $3.7 million for the month. We had budgeted a loss of $4.4 million for the month of July. So we did $700,000 better than what we expected. So that's a good thing. When you factor in also investment earnings for the month, we actually had a bottom net loss of $2.5 million, which is actually $1.2 million better than what we had budgeted for a bottom line loss for the month. We take the annual budget and we actually try to forecast it month by month. Melinda and Jennifer Stockton and our team does that. We fully expect that the first 6 months are going to be the toughest. That's when we're really going to experience those operating losses. But there's a lot of initiatives that we have going, that we've implemented or will be implemented, that we think the last 6 months will actually be more positive and even could move into the black. So we're just going to have to kind of test our resolve, gut it out, kind of stiffen up a little bit through the first 6 months and understand that it's going to be tough, and not to panic. If we continue to, like July, even though it's a loss, if we outperform, what we thought we were going to lose, then we should be positioning ourselves, to potentially do better than we had budgeted. We finished the year having achieved our minimum days cash on hand requirement, our minimum debt service coverage requirement. So those two things that knocked us out of our debt covenant compliance last year. We'll be able to report June 30, 24, we achieved it. We have to do it 1 more year before we get out of essentially that non-compliant position, and that $18 million that we had to set aside in a trust for debt service, we will get to bring that back into our cash reserves.
So question, why do you forecast the first 6 months to be the hardest?
So like payer increases. So Medicare payment increases don't go into effect till the beginning of the federal fiscal year, which is October 1. That is a big one. Our number of our commercial health plans like Anthem Blue Cross or Blue Shield, those increases going into effect in November. While they're modest increases in net revenue, They don't come in till the latter part of the first months. There are also things, continue to work on reducing our length of stay, becoming more efficient, looking to potentially not fill open positions that are budgeted, but we're going to work to not have to fill them. So lots of different initiatives that were built into the budget that we will be implementing in these first 6 months, but they really don't start bearing fruit until pretty much the last 6 months of the year.
Okay, thank you. What about FEMA funds? You've mentioned in the past that we have been awarded
Yes.
quite a lot, but have we received anything?
Yeah, great question. So I don't think we received a penny yet, but they fall into a couple categories. So one is called obligated. So once they've been obligated, it means that they've gone through the entire FEMA review process, which is exhausting. I mean, it is the epitome of bureaucracy. I can't begin to adequately describe the levels of review and all of the different federal agencies that have to bless, a claim. And I don't know if this applies to every disaster, a fire or a flood or a hurricane, if they go through all those steps. But without a doubt, it's been more complicated because FEMA has never dealt with a disaster or catastrophe that's driven by a health pandemic. So trying to, they've classified COVID as a disaster, but trying to quantify and measure the cost of that disaster has been very challenging for them. And the analysts that are working, they've never dealt with this before. So we actually have 4 projects, 4 claims that are now in the obligated category, meaning that the only thing left to do is for FEMA to write the check. Otherwise, everybody is signed off on it. We have one for $191,000 to reimburse us for the cost of providing screeners at every one of the doors that enter a CWEA facility. So you may recall that we had to hire people and put them at every single entrance in every single facility throughout CWEA to take somebody's temperature, to go through the COVID questions with them. And so those aren't positions that are normally staffed. So $191,000 directly related to COVID would not have been incurred had it not been for the pandemic. Infection control. So all the different things that we had to purchase, disinfectants and hiring more infection prevention folks, probably lots of other things that led to that. That was $187,000. Personal protective equipment, gloves and gowns and face masks and all those things, $135,000. And then the cost of testing our patients, our employees, for them to be able to come to work, buying the test kits and hiring the staff to perform the testing. That was another $14,000. So those have all been obligated. The 2 biggest claims we have relate to contract labor, overtime, and extra shifts. Together, they are $47.7 million. That's what we spent to hire traveler nurses primarily, but also respiratory therapists, other physicians, paying overtime, extra shifts throughout COVID. We literally had to demonstrate to FEMA, a traveler by name, and to show FEMA which patient who had a primary diagnosis of COVID did that traveler take care of, and for how many hours, and what did we spend on it. So we had to go down to that minute level. The first of that $47.7 million is a $33 million claim. That claim is just on the verge of going into that obligated category. We've now had it sail through pretty much every level of review. And so we're feeling very confident that that one will be approved. The last one is about 14.5 million, and it's also the travelers, the overtime, and the extra shifts. We had to separate them into 2 time periods. So that one still has a ways to go through the various review processes. What's disappointing to hear is here we are on the verge of getting this $33 million check cut by FEMA, but they just informed us last week that they've run out of money. That because of the natural disasters that we have been experiencing as a country, we've had flooding, we've had hurricanes, obviously we're experiencing a lot of wildfires here in California, and so the monies are all being spent to fight those disasters or to help with recovery efforts. So once again, we pretty much have told we're the last priority. And until Congress refunds FEMA to a level that will allow them to pay these claims, we're just going to have to sit tight. I think I shared with you that Community Regional Medical Center, I talked to their CEO a few months ago. They have a $150 million FEMA claim pending before FEMA. And then I was with the District Hospital Leadership Forum last week, and Diane Hansen, who's the CEO at Palomar Health and Escondido, they have a claim that's similar in size to ours, and they're waiting as well. So it'll be a windfall, no doubt about it. It is a one-time, source of revenue, but it will be, very, very welcome. Will give us some breathing room, help us replenish depleted cash reserves, ideally help us fully fund our employee 401k plan, give us money for capital for things that we've had to kind of defer without having the resources to do that. So we'll anxiously await.
What time of the year do they normally replenish those funds? Or did it just start July 1st and they're...
No, so you may remember before the last continuing resolution was passed by Congress, the fund had gone dry. And then when Congress passed a continuing resolution to keep the government running, they appropriated $16 billion to put into the FEMA fund. Mm-hmm. So I don't know what it's been depleted down. We likely are going to be looking at another continuing resolution. Very unlikely that Congress, who's getting ready to go out on recess and hit the campaign trail, and then they come back for just a few days in December. Very unlikely that they're going to pass budget spending bills. Mm-hmm. So likely they'll just do another continuing resolution. I hope that they would similarly replenish the FEMA fund, but we won't know until that happens.
Yeah. Okay. Thank you. You mentioned our emergency department and not having anybody this morning admitted down there. So we are seeing a lot of patients though in our emergency department. It's a record-breaking time for us down there. It
is, yeah.
So one of the things we hear often is the wait times. It's very rare that we hear somebody gets in and out in a short amount of time.
Right.
So let's talk about the wait times.
Although I just had 2 patients this morning compliment they've never been in and out of the ED faster. And I think it was a 2 to 3 hour
okay, so
experience.
Is the fast track open?
I don't know if it was, but
okay.
with zero admin holds,
patients, yeah.
It probably was, even though we had 4 traumas come in this morning, that ED group is highly superstitious. Don't ever walk in the ED and say, wow, look, it seems pretty calm this morning.
Don't use that word.
They will run you out as fast as can be. So you're right. It is, we're going to set a record. This last fiscal year, we probably saw 100,000 visits, the highest level in our 60-year history. And we're likely to repeat that again this year based on the pace we're already seeing. So what is contributing to that? I don't know. I mean, we haven't had any recent closures of hospitals. Certainly over the years, as Lindsay and and Exeter and Alta and Kingsburg, as those hospitals closed, they reduced the availability of emergency department resources. But I haven't heard any curtailing at Sierra View or Tulare Hospital. So it's possible that, although we are seeing a lot of COVID, I mean, COVID is starting to surge. The new FLIRT variant appears to be highly, highly contagious. We are seeing more hospitalizations where COVID is the primary diagnosis. Not much death, except in elderly, really elderly, super seniors, I guess I'd say. Those with severe chronic conditions, are still very much in the woods. But all this year, we've been averaging pretty consistently 270 to 280 daily visits to the emergency department. So some, I don't know if I'd call them fun facts. How about some facts? So we produce a dashboard every month. In fact, some of you may be on the Emergency Department Advisory Council, our EDAC, which is made up of our community engagement folks, and greatly appreciate the work they do. They give us insight and consumer perspective into ED experiences, and I appreciate that they're not the least bit shy, and they're very frank and candid with us, and I appreciate that, because we're not going to get better if people suffer in silence. So I always encourage you speaking out, reaching out. So about pretty consistently 21% of the patients that visit the ED are admitted to the hospital. A determination is made that they need to be admitted. But more than 2/3 are discharged from the ED. So they come in and they're discharged home, likely. So we kind of keep, we separate the wait time of those two populations. So for those that were admitted, that roughly 21%, they waited in the ED, and this is not an average, so this is the median, meaning that 50% of the patients waited less and 50% waited more than this median figure. But the median figure is roughly 13 hours between the time the patient kind of hit the ED and was formally acknowledged, was registered into the system. From the time that they actually get admitted to the bed, they're waiting 13 hours. That's the median. Again, we recognize that half of the patients wait even longer. And I don't know what the bookends are on that. I've asked Carrie Nowesky, our chief nursing officer, who oversees the emergency department, if she might be able to develop a distribution graph so that we can see, the whiskers, as they say, on that experience. Now, for the 2/3 of the patients that are discharged from the ED, and you might have a hard time believing this, but we have no reason or motivation to manipulate the data, but the median for discharged patients is right at 5 hours. So 50% of patients that get discharged from the ED wait longer than 5 hours between the time they're registered and the time they're discharged. But 50% of the patients wait less than 5 hours. So those couple that I talked to this morning that said 2 to 3 hours, they're in that bottom 50th percentile. But we do know, we hear stories all the time of patients waiting 10, 15, 20 hours. Mental health patients can oftentimes wait for days in the emergency department because we don't have a bed open in our mental health facility. So they tend to stay the longest. Our goal that we've set, kind of our benchmark target, is for that median number of hours for a patient that's going to be discharged from the ED is 3.6 hours. For those that are going to be admitted, it's 10.2. So we are not achieving our benchmark, pretty far away from it on the discharged patients, wanting them to be out by 3.6 hours, but it taking 5 hours And again, that's not the average, that is the median. So I do apologize for the waits. I know it's incredibly frustrating. We are short-staffed in the ED. That's what doesn't allow us to open up the 8-bed Zone 6 fast track, because it's the area that we have the greatest turnover. It's hard work working in the ED. If you've been in the ED, you've seen the spectrum of humanity in the ED. I was in there just a couple of weeks ago touring with a couple of our board members, and I have prisoners chained to gurneys that are in the hallways right next to grandma and grandpa, 90-year-old, that are scared and anxious, and everybody in between. And it is incredibly busy. And so, this idea of we triage patients to the best of our ability to really prioritize those that, are at greatest risk. Those that come in by ambulance with a possible heart attack or stroke or, trauma, they get in right away. But, that patient that comes in with a stomach ache, maybe a fever, not certain what's going on with them, it's frustrating for them because they think they're getting, they go into the waiting room, we bring them in to draw some blood, maybe to do an x-ray, we put them back in the waiting room, and then we've got an exam room that opens up, but an ambulance comes in. And they don't see that. They just see, I've been sitting here forever, I can't imagine a room hasn't opened up. You don't see what's coming to the ambulance bay. You don't, it's, you don't have line of sight, unfortunately. So that's what, we're experiencing. We have 73 exam rooms. Our desire is to get people back to an exam room as quickly as possible. But what's been happening when we don't have medical surgical beds open, we only have 8 of 237 that are open this morning. Oftentimes it's 0 that are open. And so those patients that have been admitted but are still waiting in the ED, in an exam room, they start clogging things up. They're waiting for a bed to open up upstairs so we can move them up and open up that exam room. And so everything backs up from there. And so it's just been, and to be this busy in the summer is highly unusual, but it's kind of been like this since COVID, that there is really the seasonality of hospital care. It used to be the summer, things got really, really slow. Doctors went on vacation, as did patients. So, surgical volume very low in the summer as people wait, until the winter months. But that's not the case anymore. I mean, literally here we're in August and we only have 8 of 237 open medical surgical beds. So it's just been, it's been a challenging time. And I don't think we're alone. You go to Community Regional Medical Center, literally the waits in the ED, you count them in days, not hours. They made a decision to close a number of their medical surgical beds because they couldn't staff them. They're struggling also with staff. So they decided just to close the beds so that they would have an adequate number of staff on the nursing units. But now they stack their patients up in the ED. And again, I personally know of patients who literally sat on a gurney in their ED for days, finally waiting to go up to a room. So it's not just Kauai, but I don't want to make excuses. We're doing everything we can to expedite throughput, hiring. We've been trying to wean ourselves off of travelers, but we have 40 open requisitions right now. Many of them are for the ED to get it to full, consistent staffing.
So it's kind of a catch-22 though, because the question was asked to me this week, why doesn't Kauai just hire more travelers to open up the beds in the ED? But then it would do no good to open up all of the rooms in the ED if there are no beds on the floors. It would patient
for those few
experience,
patients that are in the waiting room, sitting in the hard chairs, could now wait in a bed in the emergency department. But it's going to fill up quickly. There's only 8 beds in zone 6, which is really the only zone that we consistently are unable to open. And it really was designed for low acuity, fast track type patients. So, we could, we definitely could, and we are hiring more travelers. We're trying to get to full staffing in the emergency department so that we can keep every bed open. Because sometimes it's not just zone 6. Sometimes we actually have exam rooms that are open in zone 5 or zone 2, or because we don't have, there are very strict staffing ratios in the emergency department. The number of patients that an RN can care for in the ED. And we're trying to stay within the staffing ratios. We've been fortunate that the California Department of Public Health hasn't fined us for being out of ratio. We have surveyors that are here today, and one of the things they're looking at is a complaint about staffing. And so we literally show them our daily staffing logs, unit by unit, where we're short-staffed, and all the efforts that we've made, all the people we've called to ask them if they'd come in and work an extra shift. We have to demonstrate to them, to the state, that, hey, we're doing everything possible. We've got requisitions with these traveler agencies to bring more staff on. But they also have to be, trained in emergency care. So you can't take necessarily an experienced medical surgical nurse who's used to working up on the unit and put them in the chaotic environment of the ED. So, but I assure you that we are doing everything we possibly can to get to full staffing. Lots of initiatives going on to expedite throughput on the nursing units, working with other providers in the community, skilled nursing facilities, where we could discharge a patient from the acute care hospital that really doesn't meet acute care level anymore. That's where we struggle. I mean, we have patients that stay here over a year, literally over a year, and they only needed to stay 5 or 7 days, but we have no place to place them. They have no family. We're not allowed to discharge them to the street. And so they stay in a medical surgical bed for months and months on end.
Now, everybody on this call probably received your news you could use about the Stanford contract. But do you want to just kind of summarize how that ended and why that ended?
Yeah, so it's been a couple years since we ended our relationship with, Dr. Gonzalo Carrizo and Laheb Araim, Golden State Cardiothoracic Surgery Group. We had been in a relationship with them for about 11 years. Unfortunately, that relationship soured. The two gentlemen could not work with one another, and their deteriorating relationship was spilling over into the hospital. And despite all of my efforts and Dr. Mayer's efforts to make peace, we weren't able to accomplish that. And so we were fortunate that Dr. Mayer had finished his stint in Alaska, where he had been working for a period of time. He actually, before Dr. Carrizo and Araim left, he actually was hired by them to serve in what's called a locum tenens role, where he's basically filling in gaps when they're on vacation or can't be there. And so Dr. Mayer was taking a lot of the cases. When Carrizo and Araim left, we literally put Dr. Mayer back in charge of our cardiothoracic program. He then brought on some really outstanding locum tenens, and that was the program that was in place, which was fine for the moment, but really was not the right long-term solution. So we attempted unsuccessfully to recruit new cardiothoracic surgeons to our program. They are like unicorns, so to speak. Cardiothoracic surgeons go through years and years and years of training. They're a rarity. They're hard to find. It's a highly competitive market out there. They have lots of options. And so to recruit a top-notch, top-flight cardiothoracic surgeon to Visalia, to the Central Valley, is not easy. And so we actually reached out to a number of well-established cardiothoracic programs throughout California. We're in discussions with USC, discussions with UC Davis, UCSF, other programs that we knew, were interested in having satellite programs and relationships with other communities and hospitals. When we went to them, they're like, "Hey, we're in the same boat as you are. We're down cardiothoracic surgeons. We don't have any to loan, and we ourselves are struggling to recruit." So fortunately, and I want to thank Dr. Vinod Gupta, longtime cardiologist, beloved cardiologist here at Quia. He had a relationship with Dr. Joseph Wu, who is the chair of cardiothoracic surgery at Stanford. Stanford has a long time experience operating satellite programs in different communities. You may recall at one time they were running the St. Agnes cardiothoracic program. That relationship ended some time ago. But Dr. Gupta helped facilitate a meeting with Dr. Wu and some of his executives. And after a fairly long period of time, we entered into a formal relationship with them, not to run our program, so very different than the relationship they had at St. Agnes, but their responsibility to us was to provide cardiothoracic surgeons. They would be the faculty of Stanford, they would be Stanford employees, but they would be deployed to Visalia and live in Visalia and practice in our facility. So we actually entered into that agreement with Stanford about 2 years ago. And it took probably a full year before we attracted our first cardiothoracic surgeon, Dr. Michael McLean, who was brought to us by Stanford. Unfortunately, Dr. McLean was part-time, only willing to commit to be a 0.75 FTE, or to be here, 3/4 of full-time. And so we said, okay, well, we'll start out that way. We still have Dr. Mayer, and bless Dr. Mayer for continuing, to support us. He was supposed to retire last December. He then said, "Gary, for sure I'm retiring this December. I'm hoping with this change that he might consider supporting us a little bit longer," which I'd like to say he will. But we found that Dr. McLean was not even able to spend the 0.75 time with us. He has a very robust vein practice down in Southern California. He's also a farmer. His wife and children live in Southern California. And so he was not able to really devote the time that we needed. And despite Stanford's best efforts, and I applaud them and thank them for everything they did to try to recruit additional cardiothoracic surgeons, because we really want 3 full-time CT surgeons. But despite being Stanford and the name recognition and again, they face the same struggles as everybody else. So we actually, at one time, we had a new, highly enthusiastic, by all accounts, a rock star physician ending his fellowship. He was so excited to come to work for Stanford, but he thought he was going to work in Palo Alto, not in Visalia. And so once he found out that he was going to be deployed to Visalia, as excited we were to have him, he wasn't as excited. He really wanted to be working at the renowned Stanford Health, the academic medical center. And I get that. We think our program here has a tremendous amount of appeal. You're kind of the king of the ship here, and you're just one of ideally 3 surgeons, and so you're really, really busy. You're able to make a good living. And it is a good community to live in. And so despite all those attractions, we really haven't been able to gain any traction with Stanford. And we're paying them a lot of money. And again, I hold Stanford in nothing but very high regard. We will continue to be, they will be an important tertiary hospital, quaternary hospital that we will continue to transfer patients to. Our own employees under our employee health plan go there. So we'll continue to work very closely. I speak very highly of Stanford. Again, they're not responsible for the market and the conditions and the lack of cardiothoracic surgeons. And it is tough. I mean, that's why we started our residency program. Our graduate medical education was to acknowledge the difficulty of not just Visalia, but the San Joaquin Valley in general has one of the most severe physician shortages of anywhere in the country. The ratio of physicians to patients is one of the lowest in the state. And so you imagine as you go up that hierarchy of getting into that subspecialty, and now you're at cardiothoracic surgery, the pool gets even more and more shallow and more difficult. So now that said, we have a couple of really outstanding CT surgeons that are in the hopper right now. Dr. Bansal, Bansal, I haven't met her yet. She worked here at one time as a locum tenens for Dr. Mayer, female CT surgeon, phenomenal clinical skills. Our staff loved her, our other physicians loved her. She went to take a permanent position in Missouri. Dr. Mayer said, "You'll be back. You're not going to like Missouri." And sure enough, she reached out not too long ago and said, "You're right. I'm interested in coming back." So she, I think, is coming here in October to do some locum work. We've made her an offer for permanent placement. Interestingly, when we told her about our relationship with Stanford and that she'd have to become faculty of Stanford, she became disinterested. She goes, "I really don't want to be part of this huge academic medical center and the School of Medicine and everything. I really want to be practicing as a community physician, our own program." And so when we told her that we were ending the relationship with Stanford, that re-excited her. And so I'm increasingly confident that she's going to accept our offer. And then we have a second CT surgeon that also is very interested in coming to this area and becoming a permanent member of the team. So it may have taken us a while to come around, but we may be coming back full circle to our own independent program with people that live in our community, that want to be part of our community. We're definitely involving our cardiologists and our staff in the interviewing and recruitment. We want them to be a good fit, but we also really want them to be here and to be a part of this community.
Awesome. Well, Gary, once again, we've learned a lot, and we appreciate you taking the time to answer our questions. I think the crew in here, we are probably the most educated crew about what's going on at Cahuilla Health. But we thank you for your time, and we thank those of you who have joined us, and I'm going to let you sign off.
I did. Yeah. Gosh, I mean, that hour just flew by. So again, thanks for joining us. Those that are here live or might catch this recording later, we really appreciate you tuning in today. And continuing to be a member of our community engagement initiative. As Deborah mentioned, we have a Hospital of the Future Community Advisory Committee meeting on Thursday, and hope to see as many people as possible there. And if any of you Hospital of the Future people are on this telecast, I look forward to seeing you in person in a couple days here. So hope you all have a great week, and we'll see you all next month.